Let's ask questions about this figure. What is this figure? This is a posterior view of what? Of the lower part of the pharynx, where you can see the inferior constrictor, and you can see the thyroid cartilage, and lower down it is connected to the trachea, and this arrow is indicating the lowest part of the inferior pharyngeal constrictor, coming from the lateral surface of the cricoid cartilage and runs transversely and meet in the midline. Structure inferior to this is the esophagus, and this is the first constriction of 3 in which the esophagus has. What you need to know about the esophagus: it is a bit difficult organ because of its position, and on physical examination we have no way we can put our hands on. But later on the endoscopy came in, and even later the CT scan and the MRI. Therefore doctors started to have some good amount of information about the esophagus. The esophagus is a problem because of its position. We ask ourselves, what is this image? This is a diagram of the upper part of the thorax and the lower part of the neck, and it is a diagram and showing the different parts of the mediastinum. The horizontal dotted green line indicates the separation of the superior mediastinum and the inferior mediastinum. The inferior mediastinum is divided into anterior, middle, and posterior. The heart occupies almost all of the middle part of the inferior mediastinum, and the esophagus is in the posterior mediastinum, or the posterior part of the superior mediastinum, in the front of the vertebral column, and it is also in the posterior mediastinum of the inferior part, behind the heart. That is why it has a difficult position. What is this view? This is an X-ray, but not an ordinary X-ray. It's an X-ray where first the patient is given a glass of a milky solution containing barium. Barium is radio opaque, and that means whatever the barium is going to fill is going to be whitish. Therefore the patient, once he drinks the barium, immediately lateral view or anterolateral view of the chest is taken through an X-ray, because the barium is swallowed, and very quickly the peristalsis of the esophagus pushes the barium down to the stomach. So this investigation shows the inside of the esophagus. Still, it tells some important information. Let's ask ourselves questions to extract knowledge out of this image. What is this image? This is a barium swallow, and it is an X-ray, and it is anterolateral. And let's see what the first arrow is indicating. It indicates the beginning of the barium getting down the esophagus. Then we have the esophagus posterior to the heart, and this is a useful piece of information which I'm going to tell you later on. And then the esophagus is going through the diaphragm, and then there is an intra-abdominal portion which is a short one of the esophagus, and it joins the stomach. Let's ask questions about these two images. Image number one, what is it? It's a barium swallow, anterolateral view, and this is also a barium swallow and anterolateral view. Here in this image, the right one, we can see that the esophagus is dilated, full of barium, and when you go lower down towards the orange arrow, you can see that there is a constriction, and this is called chalasia of the esophagus. Why? Because for the esophagus to function well, it needs parasympathetic nerve supply, and the parasympathetic part of the autonomic nervous system is arranged in a way that the second order neuron, or the postganglionic neuron, is in the wall of the organ. Now, if the neurons of the vagus are having a problem, the esophagus does not relax, because relaxation of the esophagus in front of the bolus is important for the bolus to go down the esophagus. So when there is problem, and the problem is not good parasympathetic supply, the esophagus is going to go into spasm, and this is called achalasia. On the left image, we can see that in this barium swallow, which is going really to visualize the outline of the interior of the esophagus, which is expected to be very regular. Here at the tip of the yellow arrow, you can see that the outline of the inside of the esophagus is not smooth curved line. Therefore, there is a problem in the mucosa of this esophagus. Let's ask questions about this image. What is this image? This is a CT scan. A CT scan is a sort of X-ray that will either take slices, X-rays of the body, or that is transverse views, or sagittal view. This is a transverse view, and where are we? This is the esophagus. Where is this esophagus? If you go down, you can see the thoracic vertebrae, and you can see the ribs joining it. If you go superiorly, you will find that the aorta is a little bit to the left, and the esophagus is not in the midline at this level. It is a little bit off the midline, and you can see the shadow of the liver, the heart, stomach, and spleen. Here is another CT scan of a normal esophagus. When we say a normal esophagus, we start to ask questions about this image. This is the normal esophagus. When we say it is normal, first of all, its outline is smooth and curved, and the lumen is also smooth and circular. This is at a lower level, at the level of the great vessels of the heart, which are just deep to the sternum, and you know the sternum, it is the central bone on the superior part of this image. And if you go to the esophagus, you can see that the trachea is in front of the esophagus. That is, in other words, the esophagus is posterior to the trachea. Here we have a comparison between a normal esophagus and a problem with the esophagus. So let's ask questions and find out where is the abnormality. Where is the loss of normal features of the esophagus? Here is the esophagus posterior to the trachea and anterior to the body of vertebra, and to the right of the beginning of the thoracic aorta. If you shift to the left image, you can see that the esophagus is having very thick wall, and there is a problem with the lumen, and this is cancer of the esophagus. Cancer of the esophagus is very bad disease. Its questions and looking for answers is what makes us learn from anything. This is a sectional view where you can see the heart, and then when you recognize the heart as a central part, you go down to find out that the esophagus is a tube running posterior to the heart, and it is collapsed. This is a description of the esophagus. What is the esophagus? The esophagus is a collapsible tube, muscular tube. Let's ask a few questions about this image. This is a diagram. Now, are you oriented where you are? It is a sagittal section where you can find the heart, the ascending aorta, and at the thoracic inlet you can see that the trachea, and this yellow arrow is pointing at the esophagus. The esophagus is posterior to the trachea, and it is posterior to the heart. Here we can use this piece of information. When a person has a posterior myocardial infarction, its features will not be so clear in an ECG. The best way to have a very good image of how extensive this infarction is to let the patient swallow under X-ray control an electrode, and stop the electrode posterior to the heart and record what this electrode is picking. You will have a much clearer image of the myocardial infarction. Help from the questions. What is this image? This is a diagram of contents of the superior mediastinum, where you can see the arrangement of structures. The first, the most anterior structures are the veins. Here is the arrow indicating superior vena cava formed by the union of two brachiocephalic veins. Then you have the arteries, the arterial system. Then you have posterior to the arteries is the trachea, and then the esophagus, and the curved arrow is pointing at esophagus, which is the most posterior part of the contents of the superior mediastinum. Now when you go down, you can see that in the inferior mediastinum, when the heart is taken out, the posterior mediastinum is going to be visible, and you can see that here is the esophagus nearer to the midline, and trachea is not there because it ends up at level of sternal angle, but you can see the thoracic aorta to its left. You have learned that the tube of the alimentary system, the gastrointestinal tract, has 4 layers. The outer is the serosa. Now the esophagus, running here in the thorax, in the inferior mediastinum, on the right side, the pleura, which is the serosa of the thoracic cavity, comes and touches the right side of the esophagus in the inferior posterior mediastinum. That's the pleura. The aorta is to the left of the esophagus. Here's a diagram of nerve supply and the nerves related to the esophagus. With the help of questions, we're going to go into some details. In the upper third of the esophagus, we have striated muscles, skeletal muscles, and they are supplied by motor branches of the vagus, which are the recurrent laryngeal nerve. Then, in the middle third, it is non-striated muscle, smooth muscle, and there are mucous glands as well, and the nerve supply comes from the vagus through recurrent laryngeal branches, because it is still within the reach of recurrent laryngeal nerves. The vasomotor sympathetic nerve supply comes from cervical and upper thoracic esophagus, middle and inferior cervical ganglia. These are the sources of the sympathetic supply from the sympathetic trunk, and upper 4 to 6 thoracic spinal cord segments. This is very important piece of information. Let's look at next. Afferent visceral pain. Pain coming from the esophagus, which is posterior to the heart. Pain is perceived via the sympathetic fibers, especially the first 4 segments of the thoracic part of the spine of the sympathetic trunk, and these 4 segments also bring pain from the heart. So if there's retrosternal pain, same distribution as pain of the heart, but the disease is not in the heart, the disease is in the esophagus. So please, if you have symptoms and you think it is angina or problem in the heart, investigate the esophagus as well. We'll ask the help of questions so that we understand what is this diagram. This diagram is showing that the esophagus is having segmental blood supply from the posterior intercostal vessels and from the thoracic aorta as well. Remember that the esophagus starts in the neck as well, and it is going to get some blood supply from the inferior thyroid artery, branches coming from the aorta. Questions, please help us. What is this image? This is a diagram of what? Of the venous system, and all other structures have been removed, and we can see that the esophagus, first of all, is in the posterior mediastinum, and veins drain to the azygous vein, which is the vein running on the right side of the esophagus, and which is ending up in the superior vena cava. When it pierces the diaphragm and comes down the abdominal cavity, around the esophagus there is a very important kind of circulation. It is a connection between the portal system and the systemic system of veins. And you know for sure that the portal vein gets into the liver to open into liver sinusoids. The lymphatic drainage is also segmental. It is going to go to the paraesophageal lymph nodes in the neck and upper thorax. It is going to join the lymph nodes, the several groups of lymph nodes around the main bronchus, then the inferior tracheobronchial tree, and if you go down it after it pierces the diaphragm, lymph drainage is going to be to the celiac lymph nodes and lymph nodes of the stomach. We have looked at the relations of the esophagus, the beginning, the end, the blood supply, the nerve supply, the lymph drainage. Now we need to go into the lumen through endoscopes. Now, when doing endoscopy of the esophagus, we have to take care of the three constrictions of the esophagus. The first one is the very beginning. The second one is the indentation made by the bifurcation of the aorta, and there is a third one lower down. And here we can see a normal esophagus from the inside. The mucosa is stratified non-keratinized squamous epithelium, where you can see normal pattern of blood vessels, and the epithelium is quite healthy because it is glistening. Try to think of questions regarding this view. When you go lower down, what are you going to see? When you go through the endoscopy lower down and you start to reach the stomach, there is a sudden change of epithelium from stratified non-keratinized squamous epithelium to columnar epithelium with glands. The two type of epithelial tissues have different color and different appearance, and here you can see that the color changes, and this is the beginning of the gastric mucosa lower down. If you look at the lumen of this esophagus, you can see that it is blackish. That is about to enter the stomach. Endoscopy of the esophagus is going to reflect lots of problems that were not seen before, and here you can see that there are areas of different color, and you can see that the lumen is going down into the stomach because you are starting to see the rugae of the gastric mucosa. What am I seeing here? I can see that the mucosa of the esophagus is bad. It is damaged. There is an area of hemorrhage and areas of ulceration. The stomach is full of enzymes and acid. If the contents of the stomach enter the esophagus, the mucosa of the stomach is used to its contents, while the esophagus is not used to the acids and the enzymes. Therefore, the mucosa of the esophagus is going to suffer from different pathological features because of the acid coming back into the esophagus. This is unphysiological direction of stomach contents, but it happens if the point of joining the stomach is abnormal, then these things happen. Here is a problem. On the left image, when you are looking at the mucosa of the esophagus, you can see all these bumps, and these are dilated veins of the esophagus. You know, the venous drainage of the esophagus is segmental, and the lower part is joining the portal system. Now, these veins are full of blood, and if they bleed, as what it happens in the right image, if they open, they bleed a lot, and this is an emergency case where you have to be treated very energetically, because the patient is going to lose a lot of blood. Why is this process happening? It is because the lower end of the esophagus has one of the connections between the systemic and the portal system, and you are supposed to know the other areas, like area around the umbilicus, retroperitoneal, and lower end of the rectum. Let us use questions to extract some knowledge from these images. If you look to the image to your left, you can see that the barium swallow and the barium is not uniform. There are black areas, and these are the dilated veins, and the barium goes down between these dilated veins. Therefore, you see this typical appearance of varicosities of the esophagus. If you look to the image to your right, you can see that the portal vein, because of cirrhosis, for example, of the liver, the veins inside the liver are being pressed upon. Therefore, back pressure will build up in the portal vein and its tributaries. Therefore, these veins dilate. This is a diagram showing the portal vein as it enters the liver, and look at the surface of the liver, which is a typical appearance of cirrhotic liver. And if you go to your right and look for the left and the right gastric veins, they are not straight veins, and they are tortuous. That is because of building up of pressure inside the veins, and as you go up, you will find that the veins around the esophagus are also dilated. Dilated vessels of the esophagus after portal hypertension is called esophageal varices. This is the plan of nerve supply of the esophagus, and you may recall that pain of the esophagus gets into the spinal cord through the same segments that pain from the heart enters the spinal cord as well. So the vagus is a cranial nerve that goes down to the thorax and the abdomen and supplies lots of parts of the alimentary system. And it is the dorsal vagal nucleus is the beginning of the nerve supply, and it is the vagus. Then, as the vagus exits the brain and comes down, it is going to give a branch in the neck, which is the recurrent laryngeal nerve. It is going to supply almost all muscles of the larynx, and it is going to supply important branches to the pharyngeal plexus, as well as the upper third, the striated muscular part of the esophagus. Then we need the sympathetic innervation. The sympathetic innervation is very important for the smooth muscle part of the esophagus, which is part of the middle third and all parts of the lower third. Now, as the sympathetic trunk comes down, okay, from T2 spinal cord segments down to T6, the preganglionic fibers will join the ganglia of the sympathetic trunk, and through the plexus it is going to be formed on the wall of the esophagus, and it is going to supply the esophageal part in the thoracic cavity. Then the same plexus is going to supply the lower part of the esophagus even down to the stomach. That is the sympathetic part. And the T2 to T6 segments of the spinal cord, they receive pain sensation from the heart as well. So when you have a patient with chest pain, take care and try to see if the problem is in the esophagus or in the heart. What is this image telling me? It is telling me that the esophagus, as it comes lower down, pierces the diaphragm and has a very short esophageal part into the abdominal cavity. There is a sudden change of kind of epithelium between the epithelium of the esophagus and the stomach. This is the junction between the two types of epithelia, and it is called the Z line, and we have seen this sudden change in one of the images of the endoscopy of the esophagus. This is the normal position of the esophagus joining the stomach. This is the point of the esophagus joining the stomach along with the presence of the diaphragm. Now this point of joint should be very efficient in preventing the gastric secretions from going up the esophagus. Now there are factors that prevent this regurgitation. This is what is called of gastric contents into the esophagus, and these gastric contents will burn the esophagus. Number one of these factors is that the esophagus joins the cardia in an angle. It is not joining it directly in straight line. The bolus comes down, passes through the diaphragm, and then turns to the left and enters the stomach. This curve or angle is one of the factors. The second factor is what you see, the yellow tissue, the fat which is present in this area. This fat also plays a part in maintaining the normal flow of food and preventing regurgitation of gastric contents. In fact, there is no thickening of the muscular wall as it joins the stomach, so there is no an anatomical sphincter. The physiologist will talk to you more about this, and even the pathologist. Read more about this and ask questions and look for answers. This is a pathological condition in which for some reason the part of the fundus of the stomach will go through the esophageal opening and become superior to the diaphragm. And you know, superior to the diaphragm is the respiratory system, the pleura and the lungs. And at this point, the regurgitation of gastric contents into the esophagus becomes free. There's nothing preventing it, and that is called hiatus hernia. It has its own reasons to happen, and it has lots of unphysiological consequences, and we will be talking about this when we talk about abdominal hernia, and the physiologist will talk about it and the pathologist will talk about it as well. Asking questions will help us to understand this image. What kind of image is this? This is a chest x-ray. What kind of view? This is a lateral view. And what do we see? We see between the tips of the arrows, we see a structure. This structure is curved, and there is what is called a fluid level. The fluid level is when you put a solution in a container, it will take its own level. And if you look at the lower arrows, then you can see that these lower arrows are indicating the two borders of the fluid level. This is a typical picture of the stomach herniated into the thoracic cavity. This is a typical image of hiatus hernia. At this point, you need to check your understanding. Take a piece of paper and a pen and try to write down what you have understood. This documentation of your understanding is going to help you, first of all, understand, and second, most importantly, you'll never forget it because you have written it down. The most powerful thinking tool, the most powerful integrating tool, and the most powerful way to give you an idea what you know and what you don't know. Basically, if you can mind map it, you know it. If you cannot mind map it, you don't know it. Let's have a look at few branches of this mind map. We have said that the esophagus as a tube has 3 constrictions, and this group of constrictions must be very well considered in doing endoscopy. Endoscopy is a tube that the patient swallows, and the measurement is taken from the point of the incisors, the teeth, and it is the violet idea. So if you follow the 3 constrictions, you follow the line and then you go to your right. There is the first at 15 centimeters from the upper incisor teeth, right? And it is at the level of cricopharyngeal muscle, the lowest part of the inferior constrictor, and it is at the level of 6 cervical vertebra. These are the keywords and the very basic information about the first constriction. The second constriction, as you go down, it says it is at 23 centimeters from the upper incisor teeth, and it is at the level where the arch of the aorta crosses the esophagus and the left main bronchus. These two structures, they make a second constriction. When you introduce the endoscope, don't push hard in these areas, because you can perforate the esophagus and injure these structures. And the third constriction is at 40 centimeters from the upper incisor teeth, and it is where the esophagus pierces the diaphragm. These are important. 3 constrictions must be considered whenever you do endoscopy. There is another subject, which is the subject of its vertical course. Is the esophagus straight in going from the lower end of the pharynx to the stomach? The answer is no. It has vertical gentle curves. There are 2 of them. The first curve is at the root of the neck to the left, little below the beginning of the esophagus. So that is the first gentle turn. And the esophagus will have another gentle curve, but it returns to the midline at the level of T5, and then it will curve to the left to cross the descending thoracic aorta before it pierces the diaphragm. Okay, so it has 3 constricted areas as a lumen and 2 gentle curves along its descent. What else? Let's see the parts. There is cervical portion, and there is thoracic portion and abdominal portion. If we go to the abdominal portion, it says it extends from diaphragm to the cardia of the stomach. It joins the stomach at the cardia, curves sharply to the left. This curve is important in keeping the normal flow of gastric contents and preventing it from going up. And it lies in the esophageal groove of the left lobe of the liver. It makes an impression on the left lobe of the liver, and here it is covered by peritoneum. That means here it starts to have a serosa, and it passes through the right crus of the diaphragm. When you study the diaphragm has vertebral origin as form of 2 crura, a right crus and a left crus. Now the right crus, as it goes up and then turns around, and at this point of turning around there is an opening of the diaphragm for the passage of the esophagus, and this is another factor in preventing regurgitation of gastric contents. And you can follow any line or any color.